Welcome back everybody, David here with Med School Bootcamp. So in this video, we're just going to do a little bit of a summary to cover the videos that we've covered previously in this chapter. This is going to be a really short overview. This is really meant to kind of supplement for you right before the day of your test. If you haven't seen the more detailed videos of each of these conditions, which we talked about throughout this chapter, I'd recommend you'd watch those at least once, if not 2 or 3 times, to really understand what's going on with the details. But this is just going to be a quick summary, a quick overview of the high yield points that we talked about in those videos. So first we're going to talk about the struvite stones, also called the ammonium magnesium phosphate, which I'll shorten to AMP. And the key association with this type of stone is that we're going to be dealing with a urease positive bug, right? It's typically an infection, typically a urinary tract infection or UTI, that is able to hydrolyze urea into ammonia and carbon dioxide. What effect does this have? Well, it causes an increased pH. So it creates an alkalotic environment, which is super useful for creating this particular type of stone. The creation of this environment by these bacteria is what allows these stones to form. A key thing they want you to know is also about the diagnostics and the shape. So for this particular stone, we have radiopaque imaging on X-ray and CT scan. That means we'll be able to see it fairly easily. Additionally, if we were to get a urinalysis, we'll be looking at rectangular prisms, sometimes also called a coffin lid shape. Now, as I said in previous videos, rarely will they just give you an image of a shape and expect you to know the kidney stone that they are referring to. Rather, it is a supplement of information. We want to use all of the questions, STEM clues, all of the information that's given to us to come up with the best answer. One of the big buzzwords for this particular type of stone includes a characteristic staghorn calculi. And this is essentially just saying that there is a massive stone in the kidney. It is a very large stone in the kidney that is very unlikely, if not impossible, to actually pass through the ureters. And that brings us to our final point about this stone, is that we're going to consider 2 different things. One of which is to treat the underlying condition. So we said this is typically due to a urinary tract infection. So if we have a urinary tract infection, of course, we're going to need to treat this patient for that infection. However, because these can present as very large stones, we're also likely to consider surgical intervention for this type of stone. Next, let's move on to our calcium oxalate stones. And I'm highlighting here that this is the most common type of stone. So we talked about several different types in this chapter, but approximately 80 to 85% of these stones are actually calcium oxalate stones. This might vary a little bit on what source you look at, but it's worth knowing that this is by far and away the most common type of kidney stone in a patient. For the key associations here, we're really going to be thinking about things that can increase the likelihood of these stones forming. So that could be an increase in calcium or oxalate, or a decrease in citrate. The increase in calcium and oxalate should make sense to you, right? Because if we have more of these stone-forming substances, such as calcium or oxalate here, they can bind together, and if they bind together, they can create a substance that is not well excreted in the urinary system, thus forming a calcium oxalate stone. So what about low levels of citrate? Remember, we said that citrate actually inhibits calcium stone formation and creates a more soluble complex in the renal tubule, which is excreted in the urine. However, if we decrease these levels, we essentially inhibit the inhibitor, or we wipe out this process, and we are now allowing more stones to form. And so this is why a patient who has low amounts of citrate in their body can actually be at a higher risk of developing these types of stones. Next, I want to talk about the precipitation here. So we're looking at an acidic environment. I want to contrast this with the one we're about to talk about, which is our calcium phosphate stone, which is more likely to occur in an alkalotic environment or an elevated pH. And the reason this is important to know is because when they give you a test question and they tell you the pH, it helps you stratify or characterize which type of stone they're more likely to be asking about. Are they talking about an alkalotic pH in which stones are forming? Because that's more indicative of a potassium phosphate stone or a struvite stone, which we just talked about. Or are they talking about an environment in which it's very acidic, where it's more likely to be a uric acid stone or a calcium oxalate stone? So separating these in your mind is really helpful for answering test questions. It's also helpful for thinking about management options. Although it's not classically the correct answer on a step 1 test question, you can always create the opposite environment. So if we say that these types of stones form in an acidic pH, well, they can make sense to you that one of our treatment options is to actually alkalinize the urine. Because if we alkalinize the urine, we're creating the opposite environment, and thus we're decreasing the likelihood of stone formation. The diagnostics here include knowing that this is also a radiopaque stone, and that is to say it's going to show up as a bright white color on X-ray or CT, and that the shape of these are sometimes described as being envelope shaped or dumbbell appearing. Finally, our last couple of management options include thiazides. And do you remember why thiazide diuretics might be helpful for decreasing the likelihood of calcium oxalate stones in the urine? That's right, because think about what is one of the primary functions of thiazides. It actually removes calcium from the urine, and thus there's less stone-forming substances to actually create a stone in the urinary tract, and thus we decrease the chance of kidney stone formation. And finally, it's important to note that we can decrease our sodium intake. And we talked about this in more depth in the actual video on calcium oxalate stones, but this is all tied to the RAS system. Recall that the reabsorption or excretion of our sodium is indirectly tied to the reabsorption or excretion of our calcium. And thus, if we decrease our sodium intake, we actually increase the reabsorption of sodium and calcium from the urinary system. So a low sodium diet increases calcium reabsorption, thus again leading to less stone formation in the urinary system. Next, we're going to talk about calcium phosphate stones, less commonly tested, but still something that does show up. The main one they want you to know for calcium phosphate stones includes hyperparathyroidism, and the reason is that this release of PTH, or excessive release of PTH, is going to do what to the body? That's right, it's going to increase the amount of calcium that's being reabsorbed from the bone and thus available in the serum. More calcium in the serum can lead to more calcium in the urinary system, leading to a higher risk of stone formation. For the pH here, we said we're looking at an alkalotic environment, or one that has a high pH, and thus a potential management option could be to acidify the urine. For our diagnostics, we are looking at, again, a radiopaque stone, thus it's bright white on imaging, with what they describe as a wedge-shaped appearance. And this essentially looks like a bunch of those little door wedges that you would use to keep the door open, the little wood ones that you stick under and kick your foot in. I hope you all remember those the way I do, but a collection of these is creating this kind of stone wedge-shaped appearance that I'm drawing here. Finally, for the management, we're looking at thiazides. Again, the reason being that this can take calcium out of the urinary system, leading to less of it that can actually form stones, and additionally decrease our sodium intake for the same reason that we mentioned over here, that lower sodium intake will indirectly increase our calcium reabsorption from the urinary system. Next, we talk about cystine stones, and the key association here is an autosomal recessive hereditary cystinuria condition. Precipitation is going to include an acidic or low pH level, and the diagnostics here include mildly radiopaque, and that is to say that on CT or X-ray, these stones might show up white, but they wouldn't be a bright white, and thus it's reasonable to think that they can potentially be missed on imaging because they don't show up as obvious as some of the previous stones that we've talked about. The shape here is worth knowing. This is a hexagonal shape, which should be fairly easy to recognize if they were to give you them on a urinalysis. And when we consider our management options here, we are looking at alkalinizing the urine. This can include giving something like a potassium citrate. We would also look at chelating agents such as penicillamine to actually bind to the substances that are going to form the stones. And finally, we can decrease our sodium intake because a high sodium intake actually leads to an increased amount of cystine excretion in the urinary system. Although the mechanism is not very well known, it's an association that we should be familiar with. And finally, the last stone we're going to talk about in this video is that of the uric acid stone. A couple key associations to remember here is that anything that causes a state of hyperuricemia, such as gout or increased uric acid levels, or potentially increased cell turnover, can increase our chance of uric acid stone formation. Increased cell turnover is referring to things such as tumor lysis syndrome or potentially leukemia. And as we've talked about previously, when a cell lyses or breaks open, the products inside of that cell are then released into the system. And so this can include higher levels of phosphate or calcium or substances that can increase our uric acid levels. It should make sense to you that the precipitation of this particular condition is an acidic environment because these are called uric acid stones. And this is probably one of the key diagnostics for this particular condition, and that these are radiolucent. Remember, I said that radiolucent, you want to remember it as radiolucent to remind you of the association with uric acid stones. This is important because when we say something is radiolucent, that means we would not see it on imaging, and thus if we took an X-ray, it would not show up. And so the classic trick question that they will get you here is that they'll give you a classic vignette with a patient that you're like, this is definitely kidney stones, right? They have the flank pain, it's unilateral, it's colicky, they might have some hematuria, all of your classic symptoms and findings. But then they say they get the imaging and they don't see a stone. A lot of students will get tricked up by this and say, oh, well, then there's not a stone. But remember, there's a particular type of stone that can actually not show up on imaging, or at least not very well, and that is the uric acid stone. So again, this is why I reiterate, we are not just using one piece of information to answer these questions. We're using a collective assessment of all the information provided to us, whether that includes labs, imaging, history, exam, to actually answer and get the question correct. And finally, the management options for this condition include alkalinizing the urine. Again, you can use something like potassium citrate. You can use allopurinol, and we talked about allopurinol's effect in that it actually inhibits the enzyme xanthine oxidase, and thus we decrease the pathway which creates uric acid. And if we decrease the amount of uric acid in the body, we decrease the likelihood of forming uric acid stones. And finally, you can decrease your purine intake because purines can go through a pathway that actually breaks them down into uric acid. And so if we decrease intake, this is another way we can decrease the total amount of uric acid in the body. Some things that are high in purine include various types of alcohol and meat. So that wraps up our summary video on nephrolithiasis. Again, if you want a more detailed explanation, I would recommend revisiting the previous videos in our chapter for that. But this is really just kind of meant to be a video that you can go to after you've watched them. Let's say you watched them, a month or two ago, you have a test coming up, or you want to just revisit the topics. This is kind of a quick overview of the high yield things that you need to know to get your questions right on test day.